Welcome to the UB Medicine Podcast. I'm Dr. Allison Brashear, Vice President for Health Sciences and the Dean of the Jacobs School of Medicine and Biomedical Sciences. In Buffalo, we love our winter sports: hockey, football, and skiing, among others. But behind these high-contact sports, there's another important story about player safety and the science of brain health. Brain health far extends beyond this field. As a neurologist, this is so important because we see delayed effects of repeated trauma on the brain. So making sure that we recover using evidence-based science is really important. For example, the NFL reported more than 90 concussions during the 2025 season. And that's a number that's a cause for concern in making sure we're protecting everyone who plays in sports. So today I'm joined by two UB experts who understand how to transform, diagnose, and treat concussions. Dr. John Leddy is a clinical professor and director of the UB Concussion Management Clinic, and he's a nationally recognized leader in evidence-based concussion care. He co-authored the development of the landmark Buffalo Concussion Treadmill Test that reshaped global practices by demonstrating that controlled, individualized aerobic exercise accelerates recovery. And Dr. Nader Nader is assistant professor of orthopedics and director of research for the Interdepartmental Concussion Research Center, and he works closely with Dr. Leddy on concussion science, and he co-developed tools like the Buffalo Concussion Bike Test and the MART in Place test. So I'm excited to hear about all these three tests. So together they developed pioneering approaches. So John and Nader, thank you so much for joining me today. So let's get right into it. First, we want to understand the basics of concussions. I think they're often misunderstood, and much of what people think about they see from big hits on the field, but really concussions are more than that. They happen in everyday sports. I know my daughter had a concussion when she was little because she got hit by a baseball bat when she was just standing in the wrong place. So it can happen anywhere. Can you tell us a little bit more?
Yeah, concussions happen more often in contact sports, like you said, but we see them in non-contact sports too. I've seen them in swimmers, volleyball players. So anywhere where you could fall and hit your head or have your head shaken up. I think one of the misconceptions about concussion that's out there is that you have to hit your head and be knocked out. In fact, most people don't lose consciousness with a concussion. And they don't necessarily have to hit their head. If you have an acceleration, deceleration force, that's enough to shake your brain up. And that could be from a body check in hockey, for example, where your neck gets whiplashed back and forth. You won't be knocked out, but in a few minutes, typically to a few hours, you'll start to evolve symptoms. And that's the key for people who are playing sports or their kids is to recognize the symptoms of concussion. Because once you recognize the symptoms of concussion, then you can start treating it right away by taking that person out of the at-risk activity.
That's so important. Go ahead. Yes.
So yeah, I want to add to that. So yes, you're right. Concussions are so common, especially in kids. Even outside of contact sports or any sports, approximately 1 in 100 children do get a concussion every year. And one of the biggest, apart from what Dr. Leddy said, another misconception is that concussions are treatable as long as you appropriately identify like the underlying symptom generators and actually provide appropriate rehabilitation treatment. So earlier the treatment, the better the outcomes will be.
So as a parent, can you just highlight what the symptoms are of a concussion so that everybody knows that it's not just the worst of the worst? What is a concussion and how do we identify it?
Okay, so a concussion is your brain is literally shaken up in your skull. And the most common symptoms after concussion are headache, dizziness, blurred vision, trouble thinking. So not processing information quickly. If your child is not answering questions like he or she typically does, that's a symptom of concussion. So any child who hits their head or gets whiplashed and has a change in behavior, and especially if that change in behavior relates to how they're relating to you, either they're more irritable than they were before, or they're not processing information, or they're complaining they're dizzy, or they have a headache, that's a potential concussion, okay? And either you want to see a medical professional if you suspect there's a concussion. If any of those symptoms arise in the minutes or hours or days after a head injury, then that should be taken to your doctor, or if it's really bad, perhaps to an emergency room. So those are the most common symptoms. Remember, a concussion, the shaking of the brain produces symptoms of the concussion. A sign would be if the child is walking wobbly, okay, not walking correctly either. So balance problems are also really common.
I want to just hone in on one point. To have a concussion, you do not need to lose consciousness. I think that's a misnomer, right? It's exactly what you said. You get hit and something's not right. Behavior, thinking, etc. But the fact that you did not black out does not mean you did not have a concussion. Do I have that correct?
Yeah, absolutely. So especially with kids in sports, it's concussions happen less than 1 in 10 times. So it's really the exception, not the rule. And again, you want to look for a change in behavior after a head injury. If you think your kid is different for some reason, even if he or she is denying it, take them out of that sport or that activity. Have your pediatrician or your family doctor check them out. And if they are complaining of severe headache and vomiting, take them to an ER. But they don't have to be knocked out. In fact, most kids are not.
So can we just unpack that a little bit? So I had 2 dear friends who were injured. One fell off a bike, like you said, just standing. And wouldn't you know, they both developed an exercise on the treadmill, and it was the protocol that you developed here at Buffalo. I was so pleased to tell them that it was developed here at Buffalo. But it used to be that we would put people on bed rest sometimes for months, and your work changed that. Tell me a little bit about that.
Well, it dates back to the 1990s when I was covering lots of sports at UB and seeing these concussed athletes. And you're right, Allison. Back then, we told them not to do anything because we were afraid that if they did something, their symptoms went up, we would damage their brain, delay their recovery. But Dr. Barry Willer, who was a professor here for many years and a brain researcher, approached me one time because he developed an interest in concussion through Hockey Canada. He's Canadian. And I told him that, some of these athletes aren't getting better, and there's got to be a better way. So I took an approach that I learned in sports medicine training, which was toward the same approach as cardiac rehabilitation. So in cardiac rehabilitation, you identify a heart rate at which you can safely exercise your heart so you don't get an angina or a heart attack. And we applied that to the brain. So we developed a treadmill test that we put the patient on, and we took them up to the point where their symptoms went up more than mildly. We took that heart rate, a percentage of it, and we gave them that to go home and train at. And lo and behold, we found that the athletes who did that versus those who didn't got better faster. And that's how it started.
That's really exciting. And you've got a bike now and other stuff.
So you're talking about the 90s, but even in the 2010s, back when I was in medical school, I remember reading, the treatment for a concussion is to sit in a dark room and rest. It used to be called cocooning back in the time. And I'm so fortunate to be part of the team that eventually changed that. So regarding the treadmill, so that is one exercise modality that can be used, but some people aren't able to walk on the treadmill. So that's why we thought about, how can we actually improve or better, provide this treatment to more people. So in patients with significant balance problems, we were like, okay, instead of the treadmill, we can use a bike. So we developed our exercise, progression protocols, and we found something that was pretty helpful. But then, and useful as well. But then we found that some people, especially in underserved areas, they don't really have access to treadmills or cycloergometers. So in these, for these people, we developed the march in place test, in which you literally just stand and march in place at an increasing tempo. So you can still do a very similar graded exercise intolerance test without any large equipment.
So it's a great heart-brain connection, right?
Yes.
You can get your heart rate up and feed your brain and do all those good things. That's wonderful. Well, we talk about, you mentioned it earlier, return to play. And I'm sure there's a lot of people who have kids. And, we also know about return to play in professional sports. What exactly does the return to play protocol look like these days?
As opposed to telling people to just rest and do nothing, return to play has evolved over the years, where we start off by saying, just for the first few days, do some relative rest, get up, walk around, don't do anything too intense, but don't stay in a dark room either. That's the worst thing you can do. And then return to play is just a graded, stepwise increase in returning normal exercise tolerance. And the nice thing about the Buffalo Protocol is now included in international guidelines, where aerobic exercise treatment is the second stage of return to play now, and it's viewed as a therapeutic stage. So it's preparing the athlete to get ready for sport-specific activity and practice. So we do relative rest for a couple days, then we want to do graded aerobic exercise. Once they're tolerating that without significant symptom increase, they can then move on to sport-specific training like passing drills in soccer or lacrosse, things like that. And once they're tolerating that, they can go back to practice and finally to contact and gameplay. So it's a stepwise progression. It takes about a week typically for an athlete to get back into a sport. So remember, when someone visits the doctor and the doctor says, oh, the concussion's over, they don't go back to play right away. They have to do this stepwise program to get back to the level of tolerance of exercise for their particular sport.
So I want to add to that. So yes, like Dr. Leddy said, there's supposed to be a stepwise return to play, and this is broken down into 6 stages. So the first 2 stages are like non-contact aerobic activity, and then you slightly add more and more dynamic motion, and then finally the last 2 stages are very sport-specific exercises, and then non-contact practice, and then finally full contact practice before they can go back into sport. So for the first 2 stages, international guidelines actually do recommend the Buffalo Concussion Treadmill Test. So not just the NFL, but even, like the World Rugby Organization, the Olympics, the Paralympics, they do recommend.
Says Buffalo on there?
It does.
Excellent.
It does. So fortunately, we've done so much research, and I mean, we've done a lot of research. Like Dr. Leddy and I, we have approximately 125 papers together on pretty most of it relating to concussion and exercise intolerance. So we have very good standardized tools with very good documentation and manuals for everyone around the world to use them in multiple languages. And we need to start working on more standardized like exertion tests, not just the treadmill test, but more dynamic tests for the subsequent stages.
So you reminded me of something, this idea of the second hit, right? So, the issue is someone has a concussion, they're taken out, they say, I feel better, and they get put back in, right? And part of what you just described is getting people completely better before they are potentially exposed to. Could you say a little bit, either one of you, about that?
Well, yeah, what we know is that, and there's research behind this, not just opinion, that if you want to recover from a concussion, you remove yourself from the at-risk activity, whether it's sport or work, and you follow this sort of treatment protocol. We know that if somebody continues to play with a concussion, one thing is they double their recovery time, generally. 2, if they get hit again, so now you're hitting a concussed brain a second time, now their recovery time is exponentially higher, and or they can really develop some pretty severe symptoms. There's something called second impact syndrome, which is rarely reported, thankfully, but it's believed to be a loss of autoregulation of the brain because the concussed brain is struck again and it doesn't autoregulate well. So that's potentially very dangerous. So we always want people to not have a second hit while they're still symptomatic from one concussion. And that's why we take them out, get them checked, and then get them into a proper rehab program. And the earlier, the better, the faster they recover.
So regarding these subsequent injuries and things, so yes, those athletes who are fortunate enough to have athletic trainers or coaches, I mean, these clinicians are supposed to observe the athlete to make sure that they're able to complete all of their but that's only available to those who have the resources to have athletic trainers and, like other people to actually observe them during these processes. For underserved like populations, it's entirely dependent on the athlete or the student themselves to see if if they can progress through these stages safely or not. So that's also another concern.
So some of this is awareness, communication, and then making sure that everybody has the resources. So John, you've talked about we can't wait until 2042 about concussion guidelines. Can you unpack that a little bit? What is this about?
Yeah, so the Institute of Medicine convened an expert panel a couple of years ago, I guess, and they came up with evidence-based guidelines for primary care doctors who see most of the concussions in the country and in the world. Most people don't go to the ER; they go to their doc or their pediatrician. When you read through them, they're really good and they're really actionable. That is that with EMRs now, electronic medical records, and AI coming on, you can incorporate some of these guidelines that are evidence-based largely into, say, a patient chart or flow record in the EMR. And they're meant to, again, provide frontline clinicians with evidence-based recommendations that they can access right away that will help patients recover. I mean, if these were implemented, say, in all the family medicine and pediatrician offices in the country, you would see the concussion outcomes improve, I think, dramatically. So, unfortunately, research shows that it takes about, you're not going to believe this, 17 years for a research finding that affects clinical medicine to make it to routine clinical practice. So, when I wrote the editorial, my point was that this information should be out there as soon as possible. If we wait 17 years to get it out there, patients are going to be waiting very, very long time before they're seeing the benefit of it. That's really why we shouldn't have to wait till 2042.
You hit on a really important point. It's about number one, awareness, and number two, communication. So I think it's incredibly important that we really think about how we implement the results of the research and your research. When your research, both of you, has shown that the treadmill, the bike, just marching in place can aid recovery so that people's brains are, continuing to function. And, brain science is so complex. So whatever we can do to get people recovered from concussions and prevent long-term injury is so very important. As things are evolving from, treating, professional athletes to kids, what's your prediction, both of you, for, concussion research in the next 5 years?
Well, fortunately, for the past 10 to 15 years, there's been a lot of, in my opinion, there has been adequate amount of funding for discovering new avenues for treatments, identifying, the next best thing. So I think we just need to, because of all of this previous research, we have figured out how to treat a concussion. We know what are the so many different impairments that can happen, and each of these impairments we have been focused on to identifying individualized care for all of these things. But now, in my opinion, the next step forward is actually improving access. So even primary care physicians have all the tools that us sports medicine physicians have when we're treating our athletes.
And now there's athletic trainers at all the major high school games and things like that as part of this awareness, right? John, you were going to say something?
The thing that remains to, I think, be researched is we're looking for objective markers of when the brain is recovered. Our clinical skills are good, but research shows that even when someone looks like they're recovered and they're back to school, they may have abnormalities of motor control or brain blood flow or autonomic function that haven't fully recovered, even though they feel fine. So the field is really moving toward, and this is where things like wearables come into play, wearable monitoring, AI, biomarkers, both in the blood or the saliva, which we're investigating even at UB, salivary biomarkers of concussion. Because the key point is when is the brain recovered? And sometimes that's a tough decision for clinicians to make. So we're looking for objective information that goes beyond symptoms and, say, a physical examination of when the brain has recovered. Is a biomarker that was up now back normal? Is there balance and motor control back to where it should be? So these are the things I think the field is moving toward, more objective biomarker identification of ongoing injury, recovery, and people potentially at risk for long-term problems. We don't know who they are. Some people, not majority, but some may be, and we want to identify markers for that early on so we can intervene early on.
That's a really important point. Nader, can you tell us a little bit about your collaboration with the Department of Defense? Because, we talked a lot about sports, but that's a big issue with people who serve in the military.
Yes, and it's very fortunate that the Department of Defense has funded a lot of brain injury research in the past, and most of our trials at the moment, and all of our trials, all of our large grants at the moment are funded by the Department of Defense. Because they are genuinely interested in the short-term and long-term outcomes from concussions, because service members do get a lot of, injuries, whether it's during training, whether it's during active combat, or even while they're playing sports at their bases, because that's also a very common cause for a concussion in the military. But apart from just these, smaller blast waves, like for example, when you're beside a large gun, every single shot that's fired does produce a blast wave that can cause a very subconcussive injury to the brain. And how many of these over years and years of training and combat, how much of that affects the brain, and how can we actually mitigate some of these damage that's happening to the brain, and how can we treat the ones that have already happened? So that's a very big focus in the military.
Yeah, that's such interesting. So concussions, from the soccer game all the way to serving the military, something that I think that we don't all think about when we think about the importance of science and concussion research, such as yourselves. So if I could just ask you, Nader, and then John, what would be one of your key takeaways that you think about the future of health for in this area for our listeners?
Well, I guess, talking about a population level, my hope is that one day, and again, it's going to be some time off, but one day we can develop a method, whether that's, again, a simple salivary test or an imaging study, that will identify the young people who might be at increased risk for long-term damage from repeated head injuries. We don't know who they are yet, and not that they would be taken out of sport, but we would counsel them that maybe you want to find a sport where you're not hitting your head all the time. That would be better for you in the long run. That's a ways off, but again, trying to identify that cohort of people early on so you can maybe prevent long-term problems or repetitive concussions would be one goal for the next sort of generation of concussion researchers to tackle.
So biomarkers that do predictive modeling for the most at risk. I think that's really important. Your thoughts?
So in my opinion, one of the biggest, so when someone gets a concussion, a concussion by definition is a mild traumatic brain injuries. In these kinds of situations, if someone goes to the ER, one of the emergency medicine physicians' main concerns is to rule out more moderate and severe traumatic brain injuries. And for this, primarily they use CTs and other forms of more advanced imaging, which if it's a concussion, then they're always going to be negative. So recently, some statistics have been last year's research. Approximately $400 million are actually spent on concussion healthcare every year in the United States in just the 12 to 25-year-olds. And out of these, the healthcare expense, out of this $400 million, approximately 40% goes to the ER just to rule out that this is nothing more severe than a mild traumatic brain injury. So I think future research really needs to focus on identifying cheaper alternatives to rule out mild and more moderate forms of traumatic brain injuries.
So you bring up an excellent point, and one I just want to wrap up with. Not only are your research improving the health of the individuals, but you're also in the future going to help us bend the cost curve, as you mentioned. And that's really taking research that's developed at a research-intensive university and really putting it into implementation, and that's what it's all about. So we're hoping to shorten that 17 years that you talked about, John, and really use the research here at UB to improve the health of our region and our country. I can't thank you enough, both personally for helping my dear friends and for everything you've done here at UB. And it's really, you've really put UB on the map, and I know you'll continue to do so. Thanks for joining us.
Thanks for having us.
Yeah, thank you for having us.
See everyone next time.